Hi, I'm Dr. Nirschl. I thought we would continue our series on bone and joint problems, and I think a good topic would be shoulder surgery. There's a lot that's been written about shoulder surgery, and the most common problems in shoulder, particularly with athletes, are rotator cuff tendon problems, which is an overuse of the tendons of the shoulder. And then another problem, which is relatively common, is the rim of the socket called the labrum, and very often in baseball folks that the labrum can be torn. And then the shoulder is a fairly shallow joint, and it's dependent upon the ligaments and the rim of the socket, the labrum, to hold it in place so that the shoulder can dislocate pretty easily. So those are three common problems. And then in the older age group, perhaps arthritis in the shoulder, and we'll touch on the surgery for all four of those issues. Starting with the rotator cuff of the shoulder, that very often can happen in young people, 15-year-olds throwing baseballs, more common perhaps in 20-year-olds, and not only in baseball throwing, but tennis players, swimmers, very often will have issues like that. And we talked in one of our other series on the non-surgical approach to how to deal with that as far as rotator cuff problems are concerned, getting new blood vessels in with good physical therapy. But now if that all fails, then sometimes surgical intervention. Now in the old days, and by old starting around 1970, there was a theory which said that the rotator cuff tendon fails by being pinched from the bone up on top of the shoulder, which is called the acromion bone, and where the collarbone comes in. But recent evidence and work that we've done here suggests that these tendons fail more likely by being stretched rather than by being pinched. And so you may have heard the term impingement as a causation, and I don't believe that that occurs in the majority of cases at this point. And I think that I started the rumor of that didn't happen probably around 1984, and I think a large part of at least the sports medicine orthopedic community has sort of come around and agreed with me at this point. But there may be a fair amount of the orthopedic community who still is kind of what I would characterize on the old theory, and that's important from the points of view if you come to surgery, because the goal of surgery really should be to repair the rotator cuff tendon, either to clean it and or if there's a full hole in the tendon to actually sew it up. And so if one is basically worried about the bone pinching on the tendon, then sometimes there's been a diversion to cutting out a lot of the bone, and that's what's called an acromioplasty. And that very often results in more pain after the surgery and a longer rehabilitation period. So we're very careful now not to get involved too much in the concepts of impingement and acromioplasty as an operative intervention. Ordinarily, shoulder surgery with rotator cuff is outpatient surgery, and the way we do things is usually you only use a sling for a few days, but you have to be careful not to really use the shoulder aggressively for a matter of months. So it's a matter of having good postoperative physical therapy, and with the surgery concentrating on repairing the rotator cuff and not being diverted into taking out too much bone, as we said, because that really slows down the rehabilitative process. So if you hear the words impingement and we're going to do acromioplasty, I'd certainly talk to the surgeon who is suggesting that, and maybe really understand what's happening. New topic would be then the labrum, and sometimes with baseball throwers particularly, the rim of the socket can be torn, and on occasion, if that's the case, and that's called a slap lesion, that's SLAP, on occasion it's important to repair that labrum, and to do that we put little anchors in the area of the socket and repair the labrum down. Many times, though, you don't need to do that, and sometimes just to clean the labrum suffices. So in the younger folks who are really high demand, throwing baseballs and so forth, you may have to repair it. In the less demands for recreational activities, maybe all we need to do is to clean it out, and that that changes again the postoperative course, so that you don't have to do so much physical therapy and so much rehabilitation. In dislocating shoulders, in other words, where the ball really pops out of the socket, on occasion, if it's the first time around, it will heal by physical therapy type things, but on occasion, if it keeps doing that, then again repair of the labrum and also the ligaments around the shoulder are helpful, and that usually can be done arthroscopically as well. But again, you have to be careful in the postoperative time period, so that it's a matter of some months before you can get back to full activity. But very often, with all of the surgeries that we just discussed, the activities of daily living, in other words, to get your hand to your mouth and to feed yourself and so forth, usually can be done within a matter of 3-4 days. But more vigorous activities, you have to be careful, and that has to be selective on the basis of the damage which occurs. So that's kind of a rundown of the soft tissue problems in terms of rotator cuff surgery. Now, there's one other thing that very often occurs in the older age category, and that is arthritis in the shoulder. Now, from that point of view, the orthopedic community as a whole has suggested that most of the time, if you have arthritis, which is a loss of the slippery surface inside the joint, that requires a total joint replacement, namely put a metal ball and a plastic liner in. Our experience, however, has been a bit different, and that is that in a lot of these shoulders, you don't need to have a joint replacement. You can get by very nicely with just an arthroscopic approach, which is to clean out the shoulder joint, smooth out any spurs which block motion, and then clean out any overgrowth of the joint lining, which is called synovium. So again, if you're in a situation where you have arthritis in the shoulder, and there's been a suggestion that you need a total joint replacement, there might be an alternative which is a lot less punishing and a lot faster rehabilitation, and that would be an arthroscopic approach. So again, I would certainly discuss that with your surgeon carefully, and in our experience, as noted, very often the arthroscopic approach will carry the day, and it's not really needed that you go on to the big shoulder replacement. Now, there are some times when there is so much deformity that shoulder replacement is certainly indicated, but as I pointed out, in most instances in the shoulder, that's not the case. So I would think long and hard about moving on with a total joint replacement when there are some other options which might not be addressed or discussed with you. So that's a thought that you might keep in mind. So with all of these shoulder surgeries, then, in my view, less is better, so you want to do what makes sense, what is helpful from a point of view of more limited surgery, and the alternatives of more limited surgery versus larger surgical interventions. So that's the primer on shoulder surgery, and we hope that helps. We'd be happy to discuss it with you at any time, so I hope that this information will be beneficial to you. We're signing off on shoulder surgery.